Congestive heart failure, understanding heart failure. I think this is one of the biggest increasing problems that we're seeing in North America. To me, this is the new biggest problem. And unfortunately, this is how the vast majority of people that I look after are unfortunately going to pass away. So we need to understand congestive heart failure much better. So thanks to the team for putting this together, this really great presentation. Take it away.
Alrighty. Hello, everybody, and thanks for joining us for our webinar today. We know that managing and treating heart failure can be a bit of a difficult journey, especially when dealing with comorbidities. So today we want to take some time to discuss some common CHF treatments, as well as the treatments associated with the comorbidities, and outlining some importance of adherence to treatment. So tonight we're going to start off with a brief overview of CHF, including what it is, some common symptoms, the classifications of your condition depending on severity, as well as following up with some discussion on treatments of CHF, then the comorbidities and their treatment plan. Then we're going to follow up with talking about adherence to your treatment plan. Finally, we're going to end off with talking on an extra note regarding Ontario Health's program relating to diagnosis and management of your heart failure condition. So what is CHF? Congestive heart failure, or CHF, is a condition in which the heart is unable to pump blood effectively, and as a result is unable to circulate blood efficiently enough to meet the needs of the body or at a high enough pressure. And as a result, patients with CHF end up experiencing a variety of cardiovascular associated symptoms, such as shortness of breath, fatigue, irregular heart rate and rhythm, swelling of the abdomen, but also of the legs, ankles, and feet, as well as a decrease in physical capabilities.
So I think we should pause here. So I think heart failure has evolved to different classifications. You're going to hear about the ejection fraction. Normal ejection fraction is about 55%, and I think people understand the concept. If the heart muscle is weak, then the heart can't pump properly, which is becoming more important. And more common form of heart failure is called normal systolic or diastolic heart failure, in which the heart is pumping, but it's pumping at a higher pressure. Just think about pipes, and if the pipe's pressure is higher, the person's going to get symptoms of congestive heart failure. So I think it's very important to understand that distinction, and you can be anywhere from totally asymptomatic initially, and the body compensates, then you develop symptoms. And some of the things I want people to think about: congestive heart failure is often a disease as we get older in life, often a disease where people have high blood pressure, taking greater than 2 blood pressure medications. People are overweight, body mass index over 30, and they might have atrial fibrillation. So if you think about that, is that one of the questions I'm going to ask everybody in this audience: do you think you have congestive heart failure now, or do you think you're going to get congestive heart failure later in life? And more importantly, how you're going to prevent it from happening, and if you have it, how to treat it better. So please think about those concepts and take it away. I'm just going to be silent for a while, because these are concepts people need to think about. Because in my mind is not if you're going to get congestive heart failure, but if you live long enough, you will probably develop some symptoms of congestive heart failure, and think about how you're going to best treat this. So I'm treating my congestive heart failure by knowing my blood pressure, being as skinny as I possibly can, exercise, and preventing my heart attack from happening in the first place. And also preventing diabetes from happening in the first place, because I look at the rest of my family is that unfortunately diabetes is rampant, heart disease is rampant. I'm 63 years of age. I don't have diabetes. I can run faster or longer, maybe not faster, but longer. I'll keep up with people. I can finish last in a marathon, but at least I can complete a marathon, and you need to complete your marathon. So take it away and really think about how you're going to live and maximize, because the last few years of your life, as you're going to hear about, once you have heart failure, 5-year mortality is 50%. So there's better ways of treating it and better ways even of preventing it. So please listen very, very carefully. Take it away.
Wonderfully put. So just moving on to talking about some classifications, as Dr. Curnew mentioned, congestive heart failure can be classified according to the limitation of an individual's ability to perform physical activity, as well as the severity of their symptoms and their discomfort. So up here we have one form of classification system. This was taken from heart.org, and it ranges in classification from A to D, A being no objective evidence of cardiovascular disease, while D being objective evidence of severe cardiovascular disease. So if you were to see a physician or even just look online for some self-assessment tools to measure cardiovascular disease, you'd find similar scales such as this. So Dr. Curnew mentioned this leading up to it, and we'll just expand on it a little bit more. So an important aspect of cardiovascular disease is ejection fraction. And ejection fraction is a measure of the amount of blood that is pumped out with each contraction by the left ventricle. And it's usually expressed as a percentage, as Dr. Curnew mentioned. So with congestive heart failure, the ability of the heart to pump blood is affected, and as a result, the ejection fraction is affected as well. So there are different classifications of heart failure depending on how the ejection fraction is affected. So an individual with heart failure and reduced ejection fraction will have their ejection fraction expressed as being less than or equal to 40%, whereas if a person has heart failure but their ejection fraction is preserved, their ejection fraction is greater than or equal to 55%. Additionally, heart failure with a mid-range ejection fraction is defined as a fraction between 40 to 55%. So we have covered heart failure with preserved ejection fraction before in a previous webinar. So if you're interested, please feel free to watch that on our YouTube channel whenever you have the time to, just to learn more about heart failure with preserved ejection fraction. And as mentioned, a very, very important aspect about thinking about your cardiovascular health is thinking about prevention, because while we can rely on our physicians to give us the best care possible and give us the best medicine possible, there is no cure to heart failure. Once you have heart failure, the only thing you can do is manage it for the rest of your life. You're going to require lifelong treatment. So an important part about thinking of your cardiovascular health, even if you don't have heart failure now, is keeping in mind that eventually some of us might, as Dr. Curnew said, develop symptoms of congestive heart failure or just cardiovascular disease in the future as we grow old. So it's important to implement lifestyle changes to prevent it from even happening in the first place. In fact, as mentioned, it is the leading cause of death in Dr. Curnew's practice, with a 50% 5-year mortality rate among patients. And now I'm passing it on to our next one to discuss treatment. Our next.
So you're going to hear a lot about treatments of congestive heart failure. And one of the things is treatment is multiple medications, multiple lifestyle changes simultaneously. And we know best how to treat patients who have systolic dysfunction. And people who have systolic dysfunction of their heart, there are 4 pillars of therapy: blocking the renin-angiotensin system, beta blockers, aldosterone blockers, and EQ and SGLT2 receptor antagonists we're going to learn about. So these are actually very important concepts. So who's going to tell us more about this?
We are, the person who is supposed to read it isn't here, but I'm happy to read it for her or to go over it.
Or put it on. I'll be glad to help you too as well.
Okay. Thanks, you guys. I'll just
put the next set of slides on there.
There we go.
Okay. So before we discuss the medications that are commonly associated with congestive heart failure, it's important to examine the pathophysiology of congestive heart failure and understand the complexity of the condition. Overall, congestive heart failure is associated with a decrease in cardiac output, and a decrease in cardiac output can lead to several cascades of events, of which 2 are shown on the slide. So first, the neuroendocrine system is stimulated with a decrease in cardiac output, which releases hormones such as epinephrine, norepinephrine, and vasopressin. And these hormones contribute to the vasoconstriction of blood vessels, which thereby increase the cardiac afterload. In other words, an increased cardiac afterload means that there is an increased amount of pressure against the heart to pump blood during systole. And secondly, the RAAS system is stimulated with a decrease in cardiac output. So when this pathway is stimulated, one would expect an increased salt and water retention and increased vasoconstriction, contributing to increased afterload. So these two mechanisms play a detrimental role in congestive heart failure, and treatments for CHF often target these areas. So throughout the next few slides, we're going to discuss some common groups of treatments. This will include an explanation of their mechanisms, as well as examples, commonly prescribed drugs, and side effects. So first, we have angiotensin converting enzyme, or ACE inhibitors, which target the aforementioned RAAS pathway. The primary role of ACE inhibitors is to inhibit the enzyme that converts angiotensin 1 to angiotensin 2. And this leads to reduced levels of angiotensin 2, which contribute to vasodilation and lowers aldosterone production. So example drugs that are ACE inhibitors include some listed here, which I feel like I will butcher if I pronounce. So take a look for yourself.
I'll tell you some of it. So basically anything ends with a pril. So every medication has a generic and a trade name. So things like from Actipril, Ramipril, or anything are all prils, and they're initially developed as blood pressure medication, so they lower blood pressure. But as you point out, in congestive heart failure, especially in systolic dysfunction, they became pivotal drugs because they block the renin-angiotensin system, and they actually prolong life. They also protect kidney function too as well. So, people say these are for blood pressure. No, they're not for blood pressure. They are lower blood pressure. They protect kidneys. They protect the heart too, especially in people with systolic dysfunction. Who have an injured heart muscle. They have some protection in people who have stiff hearts as well by lowering blood pressure as well. So these drugs have multiple properties. And the next category, I think, is ARB therapy. If we put the next slide, please. And ARBs are like ACE without the cough. And they block something called the AT1 receptor. And what we don't have a slide, I don't think today, is we have a drug called Entresto, which blocks both the angiotensin systems. The combination of the AT1 blocker, it's what they call a neprilysin inhibitor, and that's actually been shown to be even superior to ACE or ARB therapy in systolic dysfunction. And so these are categories of medications that they need to be aware of. The downside of these medications, they actually lower blood pressure, they cause hyperkalemia, ACE inhibition can cause cough, and they can initially worsen renal function. And these are called part of the sick day medication, SADMAN. So if you're not eating and drinking, you have to avoid these medications for shorter periods of time. But they overall protect the kidneys and protect the heart and lower blood pressure. Anything else you want to add to that?
Not necessarily. You covered it greatly. I was just going to mention how they function similar to ACE inhibitors. But other than that, that's I think everything we had to say for this slide.
And I guess an example as well, like just like the ACE inhibitors, they also end with the pril. These, as we've sort of highlighted here, they end with a sartan. So like we have candesartan or eprosartan. So they're sort of like formulas to some of these drugs. Essentially, they have common sort of ends to them.
Here we use something called Adhering. We have Micardis, which is, anyways, there's a whole category of medications, and won't belabor that. We have a whole sets of videos on those parts of things as well that are important as well.
Definitely. Next up, we have beta blockers, which target the neuroendocrine system. And this group of medication functions by slowing down and protecting the heart from the aforementioned fight or flight hormones, such as adrenaline and noradrenaline. So some examples are listed here. Similarly, they end in ol. And some side effects are dizziness, tiredness, blurred vision, as among other side effects, but these are commonly reported ones.
Actually, beta blockers are probably one of the best drugs. So if you have a normal heartbeat, normal sinus rhythm, you target to a resting heartbeat is 60 beats per minute. They have very small effect on blood pressure overall. They're not the world's greatest blood pressure medication, especially in older people. For young people who have a resting heart rate over 80 beats per minute, they're good at blood pressure lowering. So that they're effective, but they're a very powerful medication. The side effects are sometimes vivid dreams and cold extremities. I think, but they're such a valuable medication. They actually, improve ejection fraction, probably about the best of all these medications. Tell us more.
That's all I had to say for that side. But moving on to our last group of medications is the MRAs. And this form of medication or treatment increases urine output, as well as lowers blood pressure and reduces the fluid around the heart. However, it does not reduce potassium levels, which is one thing to note. The two widely used mRNAs are listed here on the screen. Once again, they end similarly with on. So spironolactone and eplerenone.
Yeah. So basically, tongue twisters, spironolactone and plerenone. There's going to be a new one that's coming out shortly as well. But spironolactone has been around for a long time. Eplerenone has been around for a long time. These drugs actually can affect potassium levels to a much greater degree. So you have to be very cautious about this. So again, these are part of the sick day medications.
Mm-hmm. And as listed here, they are associated with some side effects. The former is associated with potentially enlarged breasts in men and increased hair growth in women, while as the latter is associated with difficulties in sleeping, as well as dizziness and headaches.
Yeah, so basically, the really side effect is gynecomastia, or bigger breasts, in which spironolactone or plerenone does not have that particular property to it.
Mm-hmm. So treatment. Go ahead.
Yeah, one more category that just came of age is SGLT2 receptor antagonists. I can't remember. Do we have a slide of that one? I don't think we do. Is that right?
I don't think so.
Unfortunately, we don't.
Sure. So this is actually the newest pillar of therapy. So SGLT2 receptor antagonists discovered in diabetes, but more importantly, they actually protect in both systolic and diastolic dysfunction. Very valuable medications. And the two ones, well, the three of them kind of Jardiance, one, Invocano, and of course Forxiga. So these medications are instrumental in both systolic and diastolic dysfunction. And you can see that so these are called pillars of therapy. So if you have a weakened heart muscle, your ejection fraction is less than 40%. And we talk about mortality, 50% 5 years. We know.
Oh, did Dr. Curnew cut out for a second? I think, did he drop from the
He
call?
did, but I believe he's back.
Oh.
I think I'm back again.
Yeah, you're back, so, Dr. Curnew.
What was the last thing I said?
You mentioned the 50% mortality rate at 5 years.
So if you have systolic dysfunction of the ventricle, you're unfortunately going to probably pass away with a higher probability of congestive heart failure or a consequence of that. And these 4 pillars of therapy will actually prolong your life and improve your quality of life. So if your ejection fraction is less than 40%, you need to be on some form of drug that blocks the renin-angiotensin system. You need to be on a beta block. You need to be on something like spironolactone, an aldosterone blocking agent, and an SGLT2 receptor antagonist. I repeat, you need to be on all 4 of these medications if you can. Now, if you have problems with blood pressure, potassium levels, and renal function, then we have to make some adjustments. If you can't be on all these medications, unfortunately, your life will probably be shortened. So that's why we need to work carefully together and need to be very, very vigilant about your medications. And this is something that I see far too often, is people saying, well, I'm not sure the pharmacist will let you know by blood work next time. No, the answer is that you need to be part of the solution to this, because if you are sick and if you don't know your blood pressure and you don't go for regular blood work and you're not keeping vigilance of who's when they're going to be need to be renewed or not, you're increasing your mortality and decreasing your life. So be part of the solution versus part of the problem. And so side effects are a major issue. Unfortunately, is a progress and take your life. So let's be smart about this. We have perfectly good videos on this as well, so please be attentive. Next slide, please.
Awesome. So treatment can also differ depending on an individual's ejection fraction, as somewhat mentioned. So in those with heart failure with reduced ejection fraction, a combination of diuretics, ACE inhibitors, and beta blockers can be used. So it's similar to what Dr. Curnew was saying. Depending on what you have, what your condition is, you may need a variety of different drugs. So on the other hand, with those with heart failure but have preserved ejection fraction, their treatment is also dependent on their quote comorbidities and symptoms, with an aim of treatment being able to relieve those symptoms associated with the comorbidities. So someone with heart failure with preserved ejection fraction and high blood pressure can be treated using antihypertensive medications. Their treatment may also involve a combination of other previously mentioned medications such as diuretics, ACE inhibitors, ARBs, MRAs, etc. Additionally, those who have heart failure with mid-range ejection fraction, a combination of ARBs, MRAs, and a class of medications called angiotensin receptor neprilysin inhibitors can be used.
Next up in our webinar, we have comorbidities. Comorbidities is the simultaneous presence of two or more disease or medical conditions in a patient. And I know Arva talked about a few about cardio CVD comorbidities. Let's take a look at other comorbidities with other body systems, such as the kidneys, such as your kidneys, such as diabetes and hypertension. So to start off, we'll go over, next slide, please. So to start off, we'll go over diabetes mellitus, which is a condition where the pancreas either does not produce enough insulin and or the cells respond poorly to insulin. So complications that diabetes mellitus may add on to CHF is LV systolic dysfunction, increased left ventricular mass, increased left atrium size, and all of these sounds really serious. So by the end, this may result as an increase of symptomatic heart failure and deaths. So treatments to patients with diabetes mellitus and CHF is really just regulation of blood sugar. So if you're part of our other club, our sugar club, you probably heard of this, but to monitor your blood sugar, a value that we use is the HbA1c value. And although standards differ a bit, but typically we say that the healthy value to aim for is 7 to 8% for any patient. And in terms of treatments using drugs, there's two main types of drugs that are used to target diabetes mellitus. The first one being sulfonylurea, and the second one being metformin. Now, it is researchers have shown that the use of metformin is a lot better compared to sulfonylurea because of their different mechanisms, where sulfonylurea works to produce more insulin in the blood, and metformin works by increasing a cell's sensitivity to the insulin. So if you're a patient with diabetes and CHF, then it is preferred to use metformin over sulfonylurea. Next up, we have hypertension. Hypertension is a general term that refers to having high blood pressure, and our healthy value of blood pressure is 120 over 80 millimeters of mercury. And if you're a patient with 130 over 90 or even higher values of blood pressure, then you are considered a hypertension patient. Complications that hypertension may bring to CHF include atrial fibrillation and peripheral artery disease. And interestingly, hypertension is also a risk factor for CHF. So not only does it exist with CHF, but also if a patient does have hypertension, it also increases their risk of developing CHF later on. Treatments for hypertension include using alpha beta blockers that we previously talked about. Like Dr. Curnew have mentioned in the last few slides, it is a lot more preferred for patients to use beta blockers as they are a lot safer. Alpha blockers work to relax muscles, which in result leads to opening of blood vessels for smooth muscle circulation and thereby reducing blood pressure. And beta blockers work by reducing a person's heart rate and thereby reducing the cardiac output, and which reduces the rate at which blood flows into the vessels, and this can have a bit of an effect on reducing blood pressure. So next, we have renal insufficiencies, and this is a general term that refers to the kidneys of the patient not functioning properly, and this can be typically caused by reduced blood flow to the kidneys. Risk factors of renal insufficiencies include glomerulonephritis, which is essentially the inflammation of the glomerulus of the kidneys. And as I've shown on the right side of the slide, the glomerulus is the blob of blood vessels that sits in the Bowman's capsule of the kidneys. And this diagram on the right is what we call the filtering unit. So if the glomerulus of the kidneys are inflamed, then blood is not being supplied into the kidneys properly, and it's also not being supplied into the filtering unit, so it's not being filtered properly. So this basically leads to the kidneys not working properly, so hence renal insufficiencies. Now, other risk factors to renal insufficiencies include diabetes mellitus and high blood pressure, as both of these impact how blood is getting into the kidneys and thereby affecting the rate at which the kidney functions. So treatment to renal insufficiencies can include reduced salt intake and having constant monitoring of the kidneys kind of filtration status. And we do this by testing a patient's urine. So if there is certain chemicals or certain proteins per se that is present in the urine and it's not supposed to be there, we know that there's something wrong with the filtering unit of the kidneys. And monitoring should really be done it should be done constantly, but it should be especially completed after ingestion of certain drugs such as ACE inhibitor, beta blockers, aldosterone inhibitors, as these impact the kidneys function quite the most. So that concludes the comorbidity section, and we'll move on to the next section.
Yeah, so we're going to talk a little bit more about adherence to treatments. So we heard a lot about treatments and the comorbidities, but an often overlooked portion is how much the patient is actually complying with these treatments. So we'll go on to the next slide where we'll kind of explain what is medication compliance and adherence. So it's interesting, medication compliance is a little bit different than adherence. So adherence and treatment compliance work together to ensure that we're getting the optimal health for the patient. In terms of adherence, adhering usually means actually receiving your medications from the pharmacy on time and getting those refills in on time, versus compliance means actually taking them on a schedule the way that you're prescribed by your doctor. And these type of terminology can make it seem like almost like the doctor is commanding you to do something and you're obeying. So the WHO did come up with a mixed definition where they said compliance is the extent to which your behavior corresponds with agreed recommendations that you've made with a variety of healthcare providers. So treatment compliance has been examined in a variety of studies. It is a very big topic in medical literature. And one specific study really shows the different ways in which people do listen to their doctor's treatment recommendations. So in 2006, a study was published that included over 1,000 patients, and they were screened and agreed to participate, and they did have heart failure as well. And it was interesting because 98.6% of patients actually did say that they try their best to comply with their medication schedules, and they do try to take their medications on time. But we'll see that when it goes into lifestyle factors, that percentage goes down vastly. So we go from 98% with medication, but then we have 79% reporting following a low sodium diet that was recommended. And then 70% complying with recommended fluid restrictions. So not drinking as much water and limiting the sodium. That's very important for heart failure. And then 35% only said that they will actually do like daily weighings and take weight loss measures. So it's interesting because what they gathered from this study was that the beliefs that people had about compliance with medication and diet were a really big factor that contributed to the patient outcomes. So those who spent time doing research and understood why they were doing these treatments were a lot more likely to comply, or those who had spoken with their doctor at length about these treatments were a lot more likely to comply with the treatments versus those who didn't really understand why they're taking something. They just know that they're taking it. So a really great way to understand more about compliance and treatments and medication and diet is to spend time doing research, but also watching these webinars, which really summarize a lot of information that could be relevant to you if you have heart failure as well. And understanding what you're putting in your body and why, because that will make you a lot more motivated to stick to a proper treatment plan that is essential. Because as Dr. Curnew mentioned, The high mortality rate for heart failure is a thing. So it is important to minimize your chances and lower that mortality rate by sticking to a proper treatment plan that includes both medications and lifestyle changes. So there are quite a few dangers of self-dosing, and underdosing, low dosing and overdosing can both have very extreme risks. So if you're self-dosing and taking less of your medication or skipping doses, you could have a very much increased risk of hospitalization and death, because especially for heart failure, there are reasons why you're on these medications, as we went over all the treatments. So it is important that you're complying with those just to lower your risk of having anything happen to you and having any severe incidents. It's also very relevant because in terms of overdosing or underdosing, you could be taking other medications, which will also really increase the likelihood of something happening to you if you're switching around your dose and self-dosing, because you never know what those medications are and how they will interact with the ones you're taking if you're not taking the proper dose. And if you overdose, so if you're taking too much of your medication per day, for example, if the doctor tells you need to take one per day, but you're not setting reminders or having the blister pack and you're accidentally taking 2 or 3, that can also have very serious consequences, especially with, for example, beta blockers. So beta blocker overdose can include symptoms that manifest in the airway, eyes, heart and blood, and nervous system. So it's really important to be compliant just to minimize risk as much as possible and make sure that these medications are helping you instead of making you worse. So there are interventions that can be completed to help with treatment compliance, because there was another study that demonstrated how interventions to improve adherence to medications, specifically for heart failure, significantly reduce risk of hospitalization. This is especially due to the comorbidities, which may require different medications and contribute to the worsening of heart failure if they are not taken. So some of the common reasons why people don't comply to medication in the first place is they're hesitant to fill their prescription due to price. So that has to do with the adherence. People might be picking up their medication once every 2 months instead of once a month, just because they can't afford to take that prescription. Lack of access to nearby pharmacy. So if you're having accessibility problems, accessing that pharmacy and getting your medication. When individuals have many prescriptions, it can be really hard to track refills. And of course, fear of side effects, and not understanding the actual importance of medication compliance and adherence to treatment in relation to the health. But there are interventions. So
I'm just going to pause here for a second over here. You raised some very important issues. I noticed that there's a lot of talk about side effects, but to be honest, if you go back to the initial slide, we talked about congestive heart failure. I'm short of breath, I'm fatigued, I don't feel great. Congestive heart failure makes you feel lousy. Look at these symptoms here. Swollen legs. Well, as we're overweight, hot weather, we get swollen legs. Certain medications, amlodipine is characteristic causing this effect, but the vast majority of symptoms are not the medications. The medications are your friends. And we tend to blame the medications for so many things. So I think it's really important I will tell you, for beta blockers, cold extremity, vivid dreams are the 2 bigger ones. Feeling of fatigue, shortness of breath, unwell, that's probably your congestive heart failure or your deconditioning. What we learned in people who have congestive heart failure, they haven't really spent much time being active. I just got back from Iceland, and basically I did 35,000 steps a day. We went on a tour where we're walking on a regular basis, and the average Canadian 3,000 to 4,000 steps a day isn't going to cut it if you have congestive heart failure. Most people have congestive heart failure with something called sarcopenia. Their muscles are deconditioned. They really haven't moved very, very well. So let's really have a frank discussion. We know that 80% of side effects from most of these studies are we call placebo effects. So 80% of people in congestive heart failure trials have side effects. I'll repeat that. 80% of people who have congestive heart failure have side effects. But guess what? 78% of patients on placebo, the fake pill to those medications, have the same side effects. So only about 2% of the side effects are drug related. Most of it, unfortunately, is overall medical condition that you have. I'm here walking as we're doing this webinar right now. And my plea to people is really think about what you can do to improve your health. Now, right now, as you heard about, is that the government allows us to measure pro-BNP. So we're going to measure that in people. So if you're short of breath, feeling unwell, we should talk about whether or not you should have that measured. And I think for many people, it's a good thing. So please look at our webinar on pro-BNP. If you think you might have congestive heart failure, one of the tests you need is an ultrasound test. And what is your ejection fraction? You should know what your ejection fraction is. I should know it. You should know it too as well. You heard about the Kansas City questionnaire. You should measure the Kansas City questionnaire. In fact, I'm encouraging everybody to do it. So my Kansas City questionnaire is 100. And I hope it stays that way for a long time. So, and so we talk about, we go back to this, is that 50% mortality at 5 years. We have life-saving medication, prolonging medication, including quality of life. So let's actually work properly together to solve some of these issues. Keep telling us more. And yes, if medication, is important to you, absolutely. Some of these medications are very expensive, but some of them are not expensive. So we can actually help you with some time that you're going, or even on a long-term basis. But if price is important, please let me know, because there's so many ways of dealing with that. There's the Trillium program in Ontario, for example, or finding versions that give you very good control of your symptoms as well. I'm very conscientious about price, and don't be afraid to discuss it. So if price is an issue, please discuss that with us, because we can actually do something to help.
Yeah, for sure. So that's actually one of the big things I was going to talk about, were kind of like the accessibility problems, as well as any financial restrictions that or limitations that you might have that may be causing you to not comply. So in terms of any accessibility issues with the pharmacy, it's always great to talk to your doctor because they might be able to give you more refills so that you don't always have to travel to the pharmacy. So maybe what you can do is, instead of getting a refill for 3 months, you can try to get enough medication for 6 months, so that you only have to go to the pharmacy twice a year for that specific prescription. That can be really helpful in terms of accessibility. In terms of financial limitations, I was going to mention you can speak to your local health unit or research on the Government of Canada, because they do have medication programs such as the Trillium drug program, which can support you if you're low income or you can't afford the medication, because really, ultimately, this is medication that can save your life. So it's really important to make sure that you are finding out ways that you can be receiving this care. Having a support system is great as well. So if you have someone to talk to at home, a parent, a child, a grandchild, talking to someone about your prescriptions and making them aware of what times that you need to take them, so that sometimes you can get a reminder if you haven't taken anything that day. You can have someone there to support you. Getting a good, proper disease and dose education. So talking about and researching your medication and watching these webinars are all really great. So if you're watching this webinar, you're already getting a lot of dose education, which is great, a lot of disease and dose education. And that will really motivate you to stick to your plan, because if you understand what's going in your body and why, it's going to be a lot more motivating for you to stick to your plan. And setting some goals. So what do you want to do? Set ambitious yet realistic goals, and find out how taking these medications will help you reach that goal. Because with the mortality rate being high, if you want to be alive to see birthdays and you want to be alive to see anniversaries, it's important to kind of set those goals, which will motivate you to stay on track. And of course, having things such as written reminders and blister packs is always helpful. Blister packs is especially great if you do have comorbidities and you're taking multiple medications and prescriptions. It will really help you keep track of what's going on. And most pharmacies will do that for free. And they'll make you a blister pack for like a whole month with everything listed out there. And of course, reviewing the side effects and discussing with your doctor. So sometimes these side effects can be solved very easily, and they might be something that you're very scared of, but it might in reality not.
Okay, stop effects. So is we overemphasize, what we talk about is that this is a process that we can do so much to help. And the vast majority of side effects are perceived side effects, are not real. it's your disease getting worse. So I think it's really important to really discuss with people who know what they're talking about. If you read the list of side effects on all these medications, it says diarrhea and constipation on every medication. Every medication makes you fatigued, and the answer is most of the time is the best way is to judge that versus placebo, a fake pill. Now, blister packs can be a life-saving thing or can make you stupid because it stops you from thinking, keeping track of your medication. So we have so much to offer to improve your quality of life. Is that when I started practice, heart disease was the leading cause of death. It's now number 2, cancer surpassed. And one of the greatest advances is medications. They made a huge impact on this process. And, it's not a bypass operation that's going to fix congestive heart failure for most people, or an angioplasty. It's the lifestyle changes, how much you weigh, what's your blood pressure, and what category of medications you're taking are so important. So really, really emphasize that. I think we've oversold blister packs because I think blister packs are good for people who, like you mentioned, have lots of medications and can't remember their medications, what to take. But on the other hand, it makes you not think about what you're taking, why you're taking. It's often hard to know how many pills you have left and refill. So I think it's really important as every patient to understand their medications. There's something called a med check you can have done. You can talk with your doctor, or basically look at the webinars we have on congestive heart failure and ask the right questions. So please be careful of keeping track of when you're going to run medications, who wrote the prescriptions. What I'm trying to do is when I see you, I would like to give you 100 days plus 3 repeats. So you have enough medications to last you a full year. And I'm having trouble working with patients because when they run on medications, the pharmacist will tell you. No, the pharmacist shouldn't have to tell me because they want to renew one prescription at a time. I want to renew them all simultaneously and get them right. You deserve to get your medications right, and we do this in an organized fashion. And so that's what I think about blister packs. They don't make it harder for you to do that. So be proactive in this. And if you don't want to take medications, you're going to say we all have a certain limit. Just talk about that. We'll decide what medications we should make for priorities. But the bottom line is that in congestive heart failure, especially if the heart muscle is being injured, is that we have so many pillars of therapy to prolong life and to improve quality of life, period. Tell us more.
Yeah, so I'm all done talking about treatment adherence and compliance. So I will pass it on to the next person.
And the next person is me. So we just want to end off with an extra little note. Just moving on to the next slide. Of course, a great aspect of treatment involves monitoring your condition. And one way to do that is using self-administered tests to monitor your heart failure status, like the KCCQ, as mentioned by Dr. Curnew. The Kansas City Cardiomyopathy Questionnaire, or KCCQ, is a self-administered test that can be used to assign a score to your symptoms. And these scores are then tallied to give you a final number that is reflective of your heart failure status. So generally, a score that is greater than 75 indicates excellent or good health status. 50 to 75 indicates good or fair health status. 25 to 50 indicates poor to fair health status, and under 25 indicates poor health failure status.
It's basically like your exam, the 0 to 100 score. So I think we understand what 0 means. We know what 100 means as well. So it's quite an easy scoring system. But I would think that everybody should just do this at least once a year. And if you have congestive heart failure, it's a great way of monitoring every 3 months or so. And I think we provide the link. We have a webinar on that. You can calculate that for you. You can calculate that yourself if you want to. Daniel, do we have that in the presentation today, how to do that?
It's not in it right now, but I can add that into the description right afterwards, and it'll have like it'll be a form that you can fill out, and it'll have instructions on how to fill it out and how to assign points.
And we can put the link to the Kansas City Questionnaire webinar that we did as well.
Yeah.
This is all being created for you to look at and do it. I've done it.
Definitely. This test is incredibly useful to monitor your progress and your condition status at home regularly. So consider doing that if you feel comfortable doing so. And as Dr. Curnew was saying, onto the next slide, we've already made a video fully dedicated to discussing heart failure, monitoring it, and the KCCQ. So feel free to watch that if you'd like to get more information and a more in-depth look at that. Now, we have an extra note that we thought would be important to include in today's webinar. We've discussed proBNP before, and Dr. Curnew talked about it earlier in the presentation. It's a marker, if you're familiar, it's a marker of health failure status, as well as a useful monitoring and diagnostic tool. So currently there is an Ontario Ministry of Health and Long-Term Care pilot program that is offering proBNP tests for free. And this can be something important to discuss with your doctor, as it could be a potential tool alongside your other tests that you're undergoing to monitor, manage, or diagnose your condition. This program is running until March 31st, 2023. So it could be useful to use this opportunity to have some tests done with no additional costs. And we also
so the test is, it does cost $80. It's now funded from the ministry until March of next year, whether or not they'll extend that. So it's coming out of the OHIP pool, or out of your tax dollars at this point in time. We need to use it wisely. It's an expensive test. And again, we have a webinar for that. And I encourage everybody to take a look at that webinar and discuss whether or not we should do that for you. So people who have a diagnosis of congestive heart failure, it tells you a lot. So BNP, it's called brain natriuretic polypeptide. It was discovered first in the brain, but we found it's found in large quantities in the heart. And the higher the pressure in the heart, the higher this value goes up. And so we can look at a value over 125 as a proBNP. BNP is another marker, roughly 3 times, you have to divide proBNP by 3 to get that number. But right now, proBNP is the marker that's being funded by the government. It's probably the best marker. And any value north of 125 is elevated. Tends to go up as we get older, tends to go up in renal dysfunction, tends to go down as we get overweight, and it tends to go up in atrial fibrillation. So it's not a simple variable, but it helps myself help you in telling you how severe your congestive heart failure is, what your prognosis is, and whether that confirms the diagnosis as well. So it's not 100% guaranteed. You can have congestive heart failure, low proBNP, but most of the time it's elevated, and it gives us prognostic as well as very useful clinical diagnosis. The most valuable is when you're uncertain, and that's basically when the heart's pumping at a higher pressure, because if you're overweight, you're going to be short of breath and you're weak. You haven't exercised, you're going to be weak, and you have weak muscles. You're anemic, so you don't have the ability to pump blood through your body because your red cell count is low. You might be depressed and sad, and that might make you feel fatigued and short of breath as well. You might have underlying lung disease, or all the combination of the above. So the proBNP can help point us how much of your feelings of shortness of breath and fatigue are coming from your heart and from other conditions as well. So I think it's a very valuable test. So please take a look at that video. Again, we'll put a link to that, and then we can decide whether or not we should measure that. Thank you for reminding us about that. Doing homework for everybody.
Yeah. So just moving on, finally, we wanted to say that we have a 3-part collection of videos discussing what CHF is, the different types and classifications, blood tests, management, and treatment. A lot of useful information if you're interested. And it would give you a great overview of congestive heart failure if you're looking for more information. And thank you very much. That was our webinar for today. If you have any questions, feel free to email us.
Wonderful. So to summarize, we start off in saying is that congestive heart failure is a disease where the heart cannot deliver adequate blood supply because of a weakened heart muscle, or because the heart's working at a higher pressure, or a combination of all of the above. Congestive heart failure is a clinical diagnosis that you can make with your physicians. And unfortunately, once you're hospitalized with congestive heart failure, recurrence admissions, it weakens your heart and we need to evaluate that. So part of the repertoire is to know what your ejection fraction is. So as a patient, you should think to myself, what is my ejection fraction? What is my Kansas City questionnaire? Is it at 65 or 75? How can I make that better? Do I have atrial fibrillation? Do I know my blood pressure? Do I know my weight? Am I doing my 10,000 steps a day? Or I'm just going to say, well, I have a couple of years left and I'll just, end up in the nursing home and that's good enough for me. But for me, that's not good enough. There's so much you can do. We have so many pillars of therapy to help you and so many lifestyle changes. And so one of the things I worked very hard at keeping myself as fit as I possibly can, keeping mentally sharp as possible. And I encourage you to do the same as well. And this team has put together a wonderful presentation, something to think about. So what's my weight? What's my blood pressure? How much activity am I going to do? Am I having trouble with my medication? Can I afford my medications, or do I think my medication may be having side effects or not? Far too often, we blame the medications for the disease process that's taken over our lives and weakening us over time. So thank you for reminding us about this. So I hope everybody will take this at heart and will take the steps to find out what's going to happen to them and how they can actually improve their quality of life. And thank you again.
Perfect.
Daniel, what do you think?
Yeah, I mean, honestly, you kind of summarized it already, Dr. Curnew, but if I go back to just this one slide here that I really was surprised about, the 35%, only 35% of, people with heart failure are, weighing their blood pressure or sorry, taking their weight and such. And I was curious, I don't know, Nisa, did this study mention blood pressure reading as well, or was it just the weight?
I don't believe so. From what I understand, like that was something that the study chose not to explore. It was
Mm-hmm.
mainly just these like four subtopics. And it was interesting because they took this all from basically they recruited the participants who had already been hospitalized from heart failure.
Mm-hmm.
And then this was like 6 months later where they actually got this data. So it was kind of interesting to see that like they weren't well educated on the importance of like how weight loss plays into heart failure, because although they were more aware and complying with their medications, they still didn't really look at like the weight loss aspect as the treatment.
Mm-hmm.
Unfortunately, they didn't do blood pressure, but I also agree that I think like the weight loss thing was really interesting to see how people like weigh these type of treatment options differently, even though they're all very important.
Yeah, exactly. And I was gonna say it's not that it's just taking the medications, it's or just, lifestyle changes like doing exercise or, monitoring your weight, monitoring your blood pressure. It's supposed to be you should do all of that, right? Because with as we've mentioned many times, there is that 50% 5-year mortality. So you really want to do everything in your power to, see the birthdays, see the anniversaries, right? So I just found that very shocking, the 35%.
What's also shocking is that most people don't know what they're taking, why they're taking, how many more pills they have left, don't take their blood pressure on a regular basis, don't monitor their health. And so I guess you have to decide what 50% you want to be in. We have so many ways of extending and improving the quality of your life. And so let's do it. And you should do it. And we can help you do it. And all the studies in the future, or all the studies are looking at how people are monitoring their health. The problem is you as an individual have to be part of that. You have to monitor your health, learn to understand. And you can say, I don't know how. The answer is we just give you a lot of ways of doing that. Well, one thing is what's in your blood. Look at that video, so understanding your blood work. Working with your doctor and your pharmacy. Look, when you come to me next time, bring your pills, not just a list. Know who prescribes what, how many pills you have left, and when you leave our visit, either by phone, by video, or in person, I will make sure that we're on the same page, that we agree on the medications that you need to be on, why you need to be on them, and give you enough to last you a full year. And you go to the pharmacist and say, Mr. or Mrs. Pharmacist, here's what we're taking. Let's make sure we don't run out. And if we're going to make a change, we're going to go back to talk to the doctor who prescribed the medication. So we're on the right track. I'm going to walk to the pharmacist. I'm going to weigh myself before I get to the pharmacist. I'm going to lose that 10 pounds and then have fun doing it. That's simple. Yet I know we're all imperfect human beings, including myself. We're all going to mess up from time to time, but we're going to enjoy the journey a little bit more and be part of the solution and live better. Well, thank you, everybody. I think we're going to bid everybody good night.